كل طبيب زي ما احنا اتفقنا. ارجوكوا يعني ارجوكوا everyone please be careful. مهم قوي ان الواحد ياخد اجراءات الوقايه بتاعته علشان الكوفيد 19 دلوقتي واضح ان هو very well spreading يعني ما شاء الله. فالواحد يحافظ على نفسه الاول عشان يعرف يحافظ على غيره. يعني التضحيه بالنفس مش اوقات ما بتبقاش شجاعه. ربنا يحفظكم دايما يا رب العالمين واسمع عنكم كل خير. بسم الله الرحمن الرحيم. Let's going to start ان شاء الله. احنا the last time we were يعني ended at the gated aspect. We have discussed many things about the concept of the nuclear, the myocardial perfusion imaging. We have discussed the cameras. We have discussed many things. I hope that it was a very brief discussion and it was very informative. I hope this one. But now this is a very important technology used through the gated, which is the gated aspect. What is meant by gated aspect? This is a simultaneous assessment of left ventricular function and perfusion. Long ago, before the introduction of the SPECT technology, the nuclear study of the cardiac muscle was only on as regard for a perfusion study. They were studying only the perfusion. So if we have, then our comment was that we have a normal perfusion, we have a defective perfusion, and this defect either mild defect, severe defect, or even no uptake. So these cameras, mics, close the mics, mute please. Okay, but when we started, when the technology improved and the gated aspect started, then we could have a very good achievement for the assessment or for the simultaneous assessment of the left ventricular function hand in hand with the left ventricular perfusion. And the function was very important, and it was providing us a very good complementary function, complementary factors or complementary data, because at this time most of the data coming to assess the function was coming from the echo, and most of the echo examinations were all only arresting examinations. But with the introduction of the SPECT studies, now we could obtain a stress and rest left ventricular function assessment. So it was really a very good invention at this time. What is meant by the SPECT? This is a single photon emission computed tomography scanning of the myocardium. And how we can assess this gated aspect? Now, we can through the RR interval, through the ECG. So when the patient was settled, or when the patient was laying down under the camera, very simply we connect the ECG for the heart for that patient. And it is very importantly to the patient to have a regular rhythm, like sinus rhythm. Okay, so and at this time the computer starts to analyze the RR intervals, and each RR interval is divided into pre-specified numbers of frames. So like 8 frames, like 16 frames, like 32 frames. The most wide is 8 frames. So between each R and R wave and R wave in the ECG, this is a complete cardiac cycle. Then this complete single cardiac cycle is subdivided into 8 frames by the computer. طيب هنرجع تاني بس ان احنا هنقول ان يبقى واضح ان الكلام القديم كله ما اتسمعش. طيب الجيتد اسبكت هو السنجل photon emission computed tomographic scanning of the myocardium, and this permits the introduction or the analysis of the left ventricular function hand in hand with the left ventricular perfusion assessment. So this was a very good achievement. To achieve this goal, we have to make analysis, or we have to record simultaneously the ECG of the patient while the patient is imaged under the camera, under the nuclear camera. And so for each cardiac cycle, which is denoted on the ECG by the RR interval, each interval is subdivided into specified, pre-specified numbers on the computer. And it was usually, in most of the time, it is 8 frames. So the cardiac cycle is subdivided into 8 cycles, sub-cycles, or 8 frames. We can even make subdivision of 16, 32, but the most widely spread is the 8. Okay, and these frames represent, yani frame number 1, the first frame, I will show you the figure after that. Frame number 1 usually was representing the end diastolic frame, and the middle frames, maybe 4 or 5, usually represents the end systole. The average of several hundred beats of a particular cycle length acquired over 8 to 5 minutes, 15 minutes. What is meant by that one? In order to the computer to make a very good analysis of these frames of the RR, he should take an average of RRs, multiple RRs. So he will make an average of hundreds of beats. And these hundreds of beats, he can make a one average of that one. And this average beat will be subdivided into the 8 frames we have been mentioned. From that point, we can expect that if the patient is atrial fibrillation, we cannot do a gated study. If the patient has very frequent ventricular ectopics, very frequent supraventricular ectopics, whatever the type of that one, then we cannot go for a gated SPECT. So the most important cornerstone at this point simply to have a regular heart rate for the patient, sinus rhythm mainly. If you have enhanced idioventricular rhythm, it's okay, we can do that one, but usually we don't put a patient with enhanced idioventricular rhythm without treatment and putting him under the assessment and diagnostic assessment. Anyway, but it should be a regular heartbeats. This is a very important point. In these frames, usually this is depicted into two-dimensional imaging and also a three-dimensional imaging and also three-dimensional reconstruction of the heart itself. I'm sorry, I don't have an images clear now to show you, but this is why. And also we are going again back to that. We have a quantitative and qualitative. The qualitative usually represented by a color coding. So the normal regional systolic function usually gives a very bright wall color during the systolic frames. The quantitative analysis of the left ventricular function, which is depicted after that into three-dimensional display, it will be representing the global LV function. And this is from that one, this global LV function, we can have slices that can be calculating, that can calculate the left ventricular volumes during systole, during diastole, and also we can calculate the ejection fraction. And even the ejection fraction, we can calculate it through during systolic period and during exercise and during rest. So we have to do both. This is a very good achievement actually. Here, this graph is very important. Now we can understand what we have mentioned before. This is a single cycle. If in the upper part of the figure you have a QRS, then another QRS. This is not a pure single cycle or absolute single cycle. This is an average cycle created by the computer through analysis of hundreds of beats over 8 to 15 minutes. And now he created one single cycle. We have a start of the cycle through the R wave, and we have end of the cycle through the second R wave. Look at the volume curve on the left down, down on your left hand. We started, the first frame usually starts by end the diastole, and then the end systole starts at the fourth or fifth frame. Usually this is what. And after that, the volume curve starts to increase again because this is starting the end, starting the second diastole and starting again the left ventricular filling. And look at on the right side. Now we have these projections. During these projections, we can create multiple two-dimensional images of the cardiac, of the ventricular side, of the left ventricle, with all the frames that we can, from short axis frames, vertical long axis frames, and horizontal long axis frames. And these three types of frames then create a three-dimensional reconstruction of the left ventricle during systole and during diastole, and even we can have a silhouette image of the ventricular cavity. This one is not khalas, we have. This is a very important one. Can we analyze that one? Yes, we can analyze this one. Actually, this is for a perfusion. We can go back. This one we will go back to it after that, but we will continue for these frames. Wait. Look at this one. What is meant? How we can interpret the findings of the SPECT, of the gated SPECT. Usually, we interpret the picture during stress, then during rest, and then we give the to a final interpretation. So if the patient perfusion during stress showing no defects, and then during rest it shows no defects, that means that this interpretation is normal. Right. During stress, again, if there was a defect in one of more walls, and then this defect improved on the rest, then this is a stress-induced ischemia. There is an ischemia, which a reversible ischemia. Right. The third possibility, if we have a defect in the stress, and this defect remained as a defect in the rest, then either we have a scar or myocardial hibernation. How we can differentiate between two of them? The resting defect, if it is a hibernating myocardium, it will show some improvement, but it is usually suboptimal in improvement, and this suboptimal could be mild suboptimal, moderate suboptimal, or even severe suboptimal. And in sometimes, if we remember the last lecture, the previous lecture, if we have a re-injection after 24 hours using the thallium 201, then we can find a very late uptake and improvement in that defect, and that means that we have a viable hibernating myocardium. But if this defect stays the same exactly as that of the stress, then we have a scarring myocardium. So this is the first part. The second part of the interpretation, it will be the defect location. Either it takes the anterior wall, posterior wall, lateral septal wall. This is very important. So where is the defect? What is the size of the defect? Is it small defect, medium defect, or big defect? What is meant by small, medium, or size? It means that it represents the severity, how many walls it takes. So if it is very located to the apex, maybe this is a small defect. Confined to a small area of the basal inferior wall, this is a small defect. But if it takes the whole inferior wall, then we are going to be more than one segment. So it is like that. So it is medium defect. So, and what about the severity? The severity is usually also subdivided into mild, moderate, or severe, which is absent. And what is the degree of the severity at rest? Completely reversible, partially reversible, or irreversible, exactly like possibility number 3. And after that, we are going for the gated interpretation of the regional wall motion abnormality. Regional wall motion, if we can see, we can have an interpretation for the regional wall motion, normal or abnormal. We can calculate the endostolic volume, end-systolic volume, and the ejection fraction. Can we go back again? Yes, please. Look at this one. This is very important image. We have here 6 rows of images. The first 2 rows represent the short axis frames. The second 2 rows represent the horizontal long axis frames. The third 2 rows represent the vertical long axis frames. So from the frame number, you see this one, from go up again, please, with me, from 23, 24 up to 31. All these images are the short axis frames. On the left hand at 23, usually you are starting at the apex. And at frame number 31, you are ending at the base of the left ventricle, short axis view. And the upper row is the stress image, and the lower row is the resting image. So here you can interpret first the stress, second the rest, and then you can make an interpretation of the combination of both images. the rest, the stress, and the rest, starting from 23, which is the apex, ending by 31, which is the base. And on the up and on the most right lateral, on the most right side, you will have the key of the image. So the upper wall is the anterior wall, the lower wall is the inferior wall, the lateral wall, there is a lateral wall on the right side, septal wall on the left side. And even at the base, you have starting the origin of the right ventricular cavity. I think it's very small, U-shaped black dot like that. I think you can see it, this one. So this is represents the right ventricular cavity.
ماشي دكتور احمد، لو الزوم قطع هنخش بنفس اللينك تاني يا دكاتره. لو زوم قطع علينا هنخش بنفس اللينك تاني ان شاء الله.
What do you see in this color? This is almost a yellow coloration. So now go back again to the left side of the image. You will have in all the images, you will have this one. This is the color coding. You will find this is color coding. From up, there is very bright yellow, and then maybe it is very deep, dark purple or something like that. So from the upper one, the yellow represents a normal perfusion. And while you are going down, the perfusion starts to be defective. So you have a mild defect, moderate defect, and then you have a severe defect, or even if it is black in color, then this is a no uptake at all. Total scar. There is no muscle to take the perfusion, to take the contrast. So this is, for that one, you can analyze the short axis. Go back again to the second two rows from number 30 to 38. Okay, the first one is also the stress. The second one is the rest. This is the horizontal long axis, and in that one you will have this this 8-figure or Arabic 8-figure like that. You have the septal wall on the left hand, you have the lateral wall on the right hand, you have the apex above, and you have the base downward. But where is our onset? From where we start and from where to where we end? Usually on the left side, we start off at the inferior wall. So from the picture number 13, or frame number 13 and 31, 30 and 31 represents here the septal inferior wall and the lateral inferior wall. Okay, and the apex, it's the apical inferior. Understand me? If there's something not clear, please interrupt me. This is very important to understand how to interpret. So in the frames 30 and 31, here we have, as you see, on the left side, the septal wall, the right side, lateral wall, linked with the apex on the upper part. But all that at the inferior portion, at the inferior wall of the left ventricle. And going then step by step, frame by frame, we're going upwards to cut the middle part of the ventricle, reaching to the anterior wall after that. So the frame number 37, 38, it represents the anteroseptal wall, the anterolateral wall, and the anterior part of the apex. This is very important. Clear? Then we go to the other, the last two rows. So the last two rows represent the horizontal long axis. In the horizontal long axis, we have a sleeping heart. It's like laying on his side. So we have the anterior wall in the upward, up, and we have the inferior wall down, and both of them are linked on our right hands by the apex, and also as the same. So where is our start? Where is our ending? We start on the left side. Sorry. We start on the left side by the septum, and we end on the right side by the lateral. So frame number 27, 28 represent anteroseptal wall and infroseptal wall. Frames number 34, 35, if you see them, it will be an anterolateral wall and infrolateral wall. Understand? Why the importance of that one? Because sometimes we can have defect, we can have attenuations, we can have artifacts, and these artifacts, if we don't have a good correlation between the short axis views defects and the long axis views defects and the horizontal and vertical long axis views defects, then we can interpret these defects as just a simple attenuation or a simple artifacts in the image, while the myocardium is truly well perfused and there is no problem. But if the defect was reproducible in the short axis, in the long axis, horizontal long axis, and vertical long axis, then we can mostly be sure that this defect is a true defect and there is an ischemia present in this myocardium. I hope it is clear. This is very important. So we can, as a revision again, usually in the upper two rows, this is the short axis. We start on the left side, from the left side at the apex. We end to the at the right side to the base. The upper row is the stress. The lower row is the rest. Can you see here in this image? There is the cavity. This is like a 5-figure, or this is a complete circle. In the image number 23, in the stress, the lateral wall is very bright white, but in the 23, in the resting image, the color fades a little. Not only like that, also the cavity inside the circle, it was widened in the stress, and then it comes like little bit obliterated in the rest. Actually, this is a normal finding. Sometimes you will have, sometimes we can call this, you used to call that one a transient ischemic dilatation. If during stress-induced ischemic dilatation, it was an indication for ischemia. But if this one was within a certain ratio that can be calculated inside with the computer, and also with a very normal uptake of the whole myocardial segments, then this is a normal variant. And some hearts have this problem. Otherwise, this is a normal variant. Let's go again for the revision. For the second two rows, the horizontal long axis. Usually, this is showing the septal wall, the apical wall, and the lateral wall. We start on the left side from the inferior septum and inferior lateral. We end to the right side by anterior septum and anterior lateral. In the last two rows, we have the anterior wall, inferior wall, and apex. On the left side, we start by the septal anterior, septal inferior. We end by anterolateral and infrolateral. Clear? I hope. Look at this one. This is also another normal variant. Here, this one, I think if you can take it as a screenshot, it's very important, because also there is a key here. Usually in the upper row, you have the stress. The lower row, you have the rest. And you have here in the upper two rows, this is the horizontal vertical long axis. You have the anterior, inferior, and apex, and the base like that. And we started from the septum, we ended by the lateral. Okay. The other one, the second two rows, this is the horizontal long axis, and you have the apex, lateral, and septal. Usually you start inferior to anterior. And the final two rows, this is the short axis. Usually you start from the apex to the base, and you have anterior, inferior, septal, and lateral. Why this image was very, very clearer. So this is the typical normal image of a stressed myocardium and resting myocardium. This is the typical image you will find it as a normal patient. But this one, it seems that you have a less clear image. That means that the patient might be defective. No, this is a normal variant. It is normal. So sometimes you will find many normal variants, and you have to use yourself to interpret these things as normal because of many other points. Usually you collect many data. You will collect the age of the patient, the risk factors of the patient, the degree of the exercise of the patient, the type of the exercise of the patient. If the patient was exercising through a treadmill and reaching 100% of his target heart rate at a very reasonable METs like 7 or 10.2 or more than that, then this will be much more better if the patient was only exercised by adenosine. And we will expect that the perfusion and the uptake of the substrate or of the tracer will be much more better. احنا بسم الله الرحمن الرحيم. يا رب لو صوتي كده مسموع تاني ابتدي تاني معلش. مسموع يا جماعه الصوت؟
تمام
تمام مسموع.
انا بس عايز اقول لكم الكي ده تاني هنرجع تاني اهو نتكلم على الكي بتاع الايمج بتاعتنا. ان احنا هنا عندنا الابر تو روز اللي موجودين قدامنا هم دولت اللي هم الستريس والريست اوف ذا هوريزونتال اوف ذا فيرتيكال لونج اكسس. السكند تو روز هم الستريس والريست اوف ذا vertical long axis, and the third two rows هم دولت الستريس والريست of the short axis. And the key is on the right side. This image is very important as a key, because in most of the centers this key is standardized. Sometimes we can change. Yani sometimes we start from the base to the apex, not from the apex to the base. But usually this is standardized. And you will see in some examples. I will show you some examples. So for the upper two rows, you have the stress image and rest image of the vertical long axis. And the vertical long axis, it will represent, as you see on the diagram, anterior, inferior apex, and you start by septum, ending bilateral. So now, if you start by the septum, that means that you are seeing the anteroseptal wall and the infroseptal wall. Ending bilateral, that means that on the right side, you will see the anterolateral wall and the infrolateral wall. For the second two rows, the horizontal long axis, if also it's like that, the same key, it is like this. So you have the septal wall, you have the lateral wall, and you start by inferior. So on the most left side, you will have infroseptal and infrolateral, and ending on the right side by anteroseptal and anterolateral. And is the same as in the last two rows. This the short axis. Usually you start by the apex on the left side, ending by the base on the lateral on the right side. And usually the short axis is divided into anterior, inferior, septal, and lateral. But usually I need you to know that if we are having the 17 subdivisions, if you have a 17 scoring system for the myocardium, if you remember that we have divided the myocardial segments into 17 or 20. For the 17, the first two rows in the short axis usually represent the apex proper. There is no anterior, inferior, septal, or lateral. Usually the first two rows, the first two images or two frames represent the apex proper. And after that, with the onset of appearing of a cavity inside in the center of the short axis, then you will have the apical anterior, apical septal, apical inferior, and apical lateral. I think this is very important and very clear. In this image, typically the apex represents the first two frames only, the first one frame only, and the cavity starts to appear starting from the second frame. I think this is understood and it's very clear. Here, this is another example, but this is a very, very good example of a reversible ischemia of a patient. So this is an ischemic patient. Look at the first two rows. This is the vertical long axis view. Look at that one. This vertical long axis in the anteroseptal, it's very good image. In the anteroseptal, this is the most left image number 7. But starting from image number 8, 9, and 10, you will find that the inferior wall takes a very low color in the color scaling. I think it is very clear. Now it is recent. It is not a yellow. It is not an orange. It is now a purple color. But this purple color starts to turn again into very bright yellow color in the resting image. This is a typical example of a reversible ischemia of the inferior wall. Where exactly? We start mostly at the infroseptal wall. So that means that this infroseptal wall have a defect and this infroseptal wall. This defect in this infroseptal wall is a reversible defect that denoting a viable ischemic myocardium in the infroseptal wall. What is the blood supply of the infroseptal wall? Mostly it is the circumflex, okay, the circumflex artery. So we have here that we are considering that the left circumflex artery has some problem. Sometimes there are variations, but this is the most probable. Okay, this is very important. But before we going for that one or ending with that conclusion, we should see also the infroseptal wall problem, that it should be reproducible. Let's go for the horizontal long axis, the second two rows. Where is the septum here? The septum is in the left side, and the lateral is on the lateral side. And we start from the inferior. It is again present in front of me. So the image number 8 and 9, if you see them, you will have on the septal wall, you have almost not, it's not a purple color, maybe it is coming to little bit orange, but it increased, or the uptake is very well enhanced in the resting image. That matches exactly what we have seen in the vertical long axis. So that means that this defect in the vertical long axis is again reproducible in the same wall in the horizontal long axis. Go further, then the last two rows again, and you can see the infroseptal wall that you have seen starting from the apex, even ending up to the base. You will have the whole inferior wall, and part of the septal wall is still having the same defect in the stress, and this defect is immediately improved in the rest. But I want to tell you something. If you see image number 13 on the last image on the right side of the short axis, the image here did not, in the infroseptal wall, did not improve very well. That means that this defect is not, this part of the image is still, maybe this is a scar. This is not a reversible. No. In this last image here, part of that basal part of the septum usually represents a membranous part. It is usually defective in the muscle, and in insufficient amount of the muscle to be well perfused. That means that this one, if there is no defect at all, it can appear also, and this one will be attenuation, or it will be just a normal variant. So here we cannot conclude that this one is a scar. We cannot conclude that one, because at this point, which is only apparent in the short axis, usually represent part of the membranous septum at the basal part of the myocardium. So at this moment, for that image, it's very clear that we have a reversible ischemia, actually severe grade of ischemia, representing the infroseptal wall, denoting a defect or a significant defect or significant lesion or significant disease in the left circumflex coronary artery. Look at this image also. معلش انا صايم، هستنى دقيقه واحده بس. بصوا على الصوره براحتكم، اشم نفسي بس وانا عمال اتكلم، وبعد كده نكمل كلام. طيب look at this image. ايه رايكم فيها؟ اولا we have very big defects، يعني الحقيقه very well scattered. خلينا نبتدي الاول من تحت خالص بالشورت اكسس. هنا تقريبا you don't have on the short axis على left side اللي هم last two rows downstairs خلاص in the bottom of the image. خلاص on the maximum left side you will not see an apex. So as a start you don't have an apex. This apex is a scar, because the first two images immediately you will have a central cavity, this black dot cavity. So that means that you did not see the apex. Always here in the upper two rows, we can go again to make a confirmation of what we have seen. All the lines in the vertical long axis and in the horizontal long axis are not connected. The septum is not connected to the lateral, and the anterior is not connected to the inferior. That means that there is a very big defect in the apex. So now we have a very clear evidence that this apex is almost a very ischemic and it is not reversible ischemia. It's a fixed ischemia. It means that it might represent a scarring of the apex. This is the first important point. Let's go further. Again, look again to the short axis view down in the bottom of the image. Now we are going to the right side. I'm sorry. Now we are going again to the right side. What do you see? Now here we have in the short axis the anterior wall. Still the anterior wall showing almost is not non-visualized. It's almost like that. Maybe it's like a very green color. So it's a very severe grade of ischemia and reaching up to non-uptake. Okay, if you see the color scale on the right side. So now we have this one, and this ischemia in the stress image did not improve in the resting image. In the resting image, it means that this is a fixed defect, and this fixed defect it is reproducible, present in the anterior wall in the apex, anterior wall in the mid cavity, anterior wall in the basal part. Are we sure of that one? Let's go to the other two slices. In the vertical long axis in the upper panel, you will have clearly the anterior wall and the inferior wall. Where is the anterior, which is the upper wall? It is not present. From the septum, even you just started at the lateral, so very small part. If you see on the right side, you will see the last two images only, or the last two images, which like 13 and 15, or showing that, 12 and 14, showing that you start 13 and 14, yes, showing that part of the anterior wall. But the rest images, all the anterior wall is almost defective. And this defect in the stress did not improve in the rest. So it means that this is a real scar present in the anterior wall, anterior septal wall, and mid anterior wall also. And this is very important. Now, how many segments do we have that one? We have the apical anterior, the mid anterior, we have the apical septal, the anteroseptal, and we have also the apex. Now until now, we have 4 segments that are showing severe defects. Okay, these segments are very important because now we are approaching multiple segments, and this is multiple segments reaching up to severe non-uptake, either in the stress, either in the rest. It means that this is almost a scar. That we will go again to the. I want us to go back to another slide we have discussed in the last lecture. See this one? When we have these defects, if you see that this SSS score, this is a sum stress scoring. That means that here, how many segments that we have? Probably we have more than 4 segments. We have almost 5 segments. So this is the 5 segments showing a mild abnormality. But actually, this is not the only thing. The problem is that even the sum resting score, the SRS, which is not present in this lecture, okay, it's also still defective. So now we have an addition for that one, for this SS score to be from 4 to 8. Again, we will have the same defect present in this one. So the third one, the second defect, I'm sorry. So the SS score here is from 4 to 8 for that image. Okay, we have discussed. And the SRS, which is the sum resting score, is also the same from 4 to 8. And that means that there is another, the difference between both, which is the sum difference score, SDS, then it will all be almost 0. And this will transfer us from mild abnormal to moderate to severe abnormality. Actually, I'm very sorry, I forgot totally to put this slide to make it very clear. I'm very sorry. I can send this one again. I will prepare that slide and will send it for you for the discussion for the SS score, SR score, SSS, and SRS and SDS. This is very important. I will send them to Dr. Mona, and then she can send it to you all. So now from that example, here we have multiple ways. We have here very important that we have already found that we have a scarring present in the apex, we have a scarring present in the apical anterior. We have a scarring present in the apical anteroseptal. We have a scarring present in the mid anterior, and even scarring present in the mid anteroseptal walls. This is very important. Do you think there is another findings we can get? Yes, we can get another finding from the gated here. See that cavity and see the cavity inside this one, and see the cavity in this one, and see the cavity. There is big difference between the cavities. True or not true? This cavity is dilated. This cavity represents a heart failure patient. This is a systolic heart failure patient with a severe cardiac left ventricular dilatation. So this is why. And if you want exactly very important sign or very sure sign of systolic heart failure with a dilatation and chronic heart failure also, you will find a reversible Y shape. Usually, the walls in the vertical long axis and the horizontal long axis converge to meet at the apex. But here, they are diverging towards the apex. This diversion towards the apex, showing that the apex is much more wider than the base of the left ventricle, is a very important landmark showing that this is a severe systolic heart failure, chronic systolic heart failure. It's a long-standing heart failure patient, systolic heart failure patient. This is very important point. So now we have here that one. From that interpretation again, we have in the last example, we have a defect in the stress, and it remained a defect in the stress in the rest. That means that we have either hibernation or scarring, but actually we have both. Why we have both? Because here in the apical parts of the anterior wall, look for the short axis, you will have almost no improvement at all in the anterior wall, apical anterior and mid anterior. But at the basal part of the anterior, here you started to have some coloration or some uptake of the contrast. At this some uptake denotes that there is some hibernation. So this is not the anterior wall from apex to base. The first two segments of the anterior wall, which is apical and mid, total scar, but at the base there is some uptake. It means that there is some hibernating viable myocardium. I'm sorry, this slide also, it should be before, like, anyway, from the stress gated aspect, myocardial perfusion imaging, this slide is very also important because these are the data we can obtain from the gated aspect. We can obtain, we can detect or calculate left ventricular volume, and this volume, from that one, we can calculate the ejection fraction. We can see the perfusion pattern, either ischemia or scarring. Very important also, the third thing is the left ventricular desynchronization, because some computers or some softwares can even calculate the rate of activation of the myocardial segments and the rate of delay of activation of the myocardial segments in relation to the ECG of the patient. This can, this detection is very important in the heart failure patients who are amenable to be subjected to the cardiac resynchronization therapy. This is very important. So now we are not only, we cannot only depend on the ECG criteria, then we also can depend on the perfusion nuclear criteria, because it can detect the desynchronization of the myocardium. And this desynchronization, if it is present, that means that it will predict a very successful implantation of the multi-site pacing of the or the cardiac resynchronization therapy. This is very important. Okay. Also, we have discussed that TID in the last one, which is the transient ischemic dilatation. And if this, and under certain conditions, we should know that it's sometimes, usually it is, in most of the time, it's a normal variant, but in other times, it can represent some myocardial left ventricular stunning, which is not our place of discussion now. The stress modality is part of the part of the discussion also, and we have exercise. We have already discussed the stress modalities before. What about the variations of the image? This is also, again, we can go back again to that one. The variations of the image, it means that we sometimes have defects that are not a true defect. So sometimes from our first impression of the image, we can see that this myocardium have some defect, have some wall defect. But actually, this is not like that. It is an attenuation, or it is a normal variant. Like a dropout happening in the upper septum means apical septum or basal septum. This is the basal septum. We have discussed this one. At the basal part of the septum, sometimes it will appear like a defect. Why? Because at this point, we have a membranous septum that usually is devoid of myocardium, and that means that there will it will not have a very good amount of uptake of tracer, and that means that it will not be imaged very well. So it will give us interpretation as if it is a defect, but actually it is not. It's a normal variant. Right. What about the apical thinning? Sometimes some APCs of some ventricles have a small or thinned out apex, which sometimes it's a normal variant. How we can know this one? It will not be reproducible. It's only present, actually, usually it is present in the stress, and usually it is not confined. It is improving in the rest, and usually it is accompanied by some transit ischemic dilatation. And all the apical segments and other segments are completely normal, and the patient doesn't have ECG changes, and the patient completed his exercise, and the patient doesn't have symptoms or signs compatible with myocardial ischemia. When we have all these factors present, then this is just a thinning apical thinning, which is a normal variant. Sometimes in the lateral wall, sometimes it appears very brighter more than the septal wall. Could be this happened, and mainly in the males rather than the females. This is very important also, particularly if this male was hypertensive male. So the hypertensive patients sometimes give us an impression that the lateral wall is much more brighter. That means that because if the lateral wall is much more brighter than the septal wall, then we can interpret wrongly that the septum has a defect, while it is not. So in some hypertensive male patients, we will have the lateral wall much more brighter than the septal wall, and this is sometimes a normal variant. How we can minimize all these variations? Through the review of series of normal patients and careful review of the risk factors, careful review of the ECG, careful review of the exercise data of the patient, and even very careful review of the interpretation of the images, all the segments, all the cuts of the patients through the report. Also, we have some technical artifacts, like the breast attenuation. In many female patients, particularly middle age, with like large breast tissue, then we can have some breast attenuation present mainly at the anterolateral wall. So it gives us an interpretation as the anterolateral wall has a defect, which is not true. How we can overcome these defects? If particularly if we have some obese female or something like that, sometimes we can put the patient to be in the prone position, so we can make the patient we image the patient in prone position. This will make the soft tissue of the breast away from the heart and the chest wall. We can do this one. And now we have a hybrid machines. These hybrid machines have already a CT machine, a CT head present inside the machine. So we first start by taking pictures of CT slices of the soft tissue of the chest, the segments of the mediastinum, and this soft tissue images can be incorporated in the image of the nuclear study, and this attenuation factor can be ameliorated, so giving a very good image of the heart itself, away from the soft tissue attenuation above the heart and the anterior wall and the lateral wall above the heart in the chest. I hope it is clear. The inferior wall attenuation. Inferior wall attenuation, from where it comes? Sometimes it comes from the diaphragm, particularly in the male. So in the male, we have the inferior wall problem because of the diaphragm. Sometimes the diaphragm compresses the inferior wall, giving the impression that this inferior wall have a reduced uptake, and it has an ischemic defect, while it is not. How also we can do overlap this one? Still, we have the prone position. It's the same. Still, we can we can take images through the CT. The CT head also can have a very good role in attenuating this effect, or in making us detecting this effect. And sometimes, usually, you can wait a little for the patient to have resting. Don't rush to take the image of the patient while he is still have dyspnea and tachypnea, because at this dyspnea and tachypnea, you have augmented diaphragmatic wall function. And this diaphragmatic muscle function will immediately be interpreted as an inferior wall defect, while there is no defect in the inferior wall. It's just a diaphragmatic attenuation. This is very important also. Then we have something called the extracardiac tracer uptake. You have remembered that we have talking about the technetium. The technetium is very importantly going immediately. As it is going to the heart, it goes also to the liver, and it is uptaken through the gallbladder. This is why, if the repeating image, we can give the patient, make another image if we have an inferior wall uptake. Extracardiac, inferior wall extracardiac uptake. Okay, then we can repeat the image. We can give the patient drink cold, or usually, even after the patient finish after we giving the patient his tracer, we allow him to rest a little and take some fatty meal, and this fatty meal will evacuate the gallbladder, and all the tracer that went to the liver, it will immediately be away from our image. I want to show you where is this one. Remember this image? See this image? Go down in the last two rows, the short axis. Look at the inferior wall. It seems like this is not a circle. It's like a Y letter with a vertical handle going away down there. Do you see this one? Please confirm to me in the image number 11, 12, and 13. And it is only present in the rest. It is not present in the exercise. Is this clear? This is an extracardiac. This is an extracardiac uptake. This uptake, it is present in the goal. This is a liver uptake. Okay, and this is an extracardiac, and it can be representing like that. So that means that this patient need to have if you are in doubt in this point, then you can give the patient another cold water, another fatty meal, make a repeat image, make a prone imaging, and use a CT head to make clear that this is an attenuation. This one is not important. This one we have discussed. This is very important. I need just to point that with a normal SPECT MPI scan, the annual risk of death is, or non-fatal myocardial infarction is 0.6. We have discussed this and I think this one we have discussed it before in the previous lecture. So if we can calculating the SSS score, it was 0.3, then it's almost normal. The patient is having a mild risk from SS score from 4 to 8, then SS score from 9 to 13, it's a moderate risk, and then more than 13, there is a high risk with annual cardiac death will be 2.9, and annual myocardial infarction will be 4.2. Actually, what is the discussion almost ended. So from now on, we will see some images and we will try to interpret together. These are patients. I'm sorry, I did not remove the names of these patients, and this is very old ones. But why I brought this one? Because this image, it have here, this key is very obvious. This is an Egyptian key, okay? And here in the last row, usually, as I told you, from the left side, we start with the inferior to the anterior, but here we were starting from anterior to inferior in the horizontal long axis. For the vertical long axis, it usually is the same. We started from the septal ending to the lateral, and from the upper two rows for the short axis, we started from the apex, we ended to the base. What do you think about this one? You can even say for each yourself, this is normal patient. This is normal patient. We don't have problems in that patient. So the uptake is even all through the stress and the rest, all through all the segments of the myocardium. And in the short axis, we really have a proper apex at frame number 8 and 9, frame number 7 and 8 in the down. But also there is, and the cavity, which is normal cavity, starts to appear at frame number 10 in the stress and frame number 9 in the rest image. And all these cavities are almost normal. There is no dilatation. All the uptake is even, and so this is a normal test for a patient. Look at this one. What do you think? This is very important. Look at the stress image in the short axis view. Look at the inferior wall of that short image, apical inferior, going step by step until maybe frame number 17. Well, okay, 17. So this is septal wall, and the septal wall is fading away through when we are going to the base. But we expect that this is a normal variant. Let's go to the resting image. What is happening in the resting image? We have some defect in the inferior wall. Usually, if you have a defective inferior wall or segment in the rest, not in the stress, then you will expect that it could be a normal variant. It is not a true. If you have a true defect, usually the defect will appear during the exercise, during the stress, and it will appear during the resting condition, because this is the ischemia. This is the normal ischemia. The ischemic patient, if he has an activity, he starts to do a physical activity, then he will have a chest pain. And this chest pain will comply him or will oblige him to stop and get rest, and then this chest pain will improve. That means that during exercise, he will have a problem, and after that, he will have this problem will be reversible, will be ending. But in this one, we don't have that one. We have a normal uptake in the inferior wall in the stress, which now we have a defect in the resting wall, which is totally opposite the normal. That means that this is an artifact. This is not a true defect. This patient doesn't have a problem in the inferior wall. This patient is having a normal variant through that there is some attenuation in the uptake in the inferior wall with several reasons. Maybe this patient, because of the diaphragmatic attenuation. So the diaphragm in the resting condition was covering the inferior wall, so the counting camera or the photomultiplier could not receive very good amount of counting through the inferior wall. So it gives this picture as there is a defect. This is important. Are you sure of that one? Yes, I am sure. Because go to the horizontal long axis, the vertical long axis image. Still the inferior wall and the rest is very good. But then after that, in the stress, it was good. There is a good uptake in the inferior wall. But this inferior wall, it looks like a defect in the resting images, which is still, again, it proves that what I am saying, or I am claiming that this one is a normal variant, because the defect here is present in the rest, not present in the stress, which is totally opposite what we know through the scheme. This one is also considered a normal variant. It's okay. Look at this one. What do you think about this one? If anyone wants to make a question, or even want to share his idea, if anyone want to reply this image, I would be very happy for that one. Anyone want to reply? Is there any problem in this image, or this patient is also normal? What do you think? Actually, it is normal. This is also one of the normal variants of the patients. These are very important. Please take screenshots of these images, because this one, if you have seen too many normals and too many normal variants, so when you see an image with a defect or true ischemia, then you can interpret it very well like a true ischemia. This is another normal variant. All these patients are normal. Look at this one. Is this a normal variant? No. Here we have almost global ischemia in the rest, that it was improved in the stress. In the stress that was almost improved in the rest. So this one, no, we have here apical ischemia, we have anterior wall reversible ischemia, we have anteroseptal wall reversible ischemia, we have anterolateral wall, so reversible ischemia. If you see from the short axis view, the apex, it was defective with a partial improvement. But after that, the anterior wall was the mostly evident, that anterior, anterolateral, and anteroseptal walls, all of them showing decreased uptake, that it was improved in the resting conditions. And this also was proved through the vertical long axis, the anterior wall, anterolateral, and anteroseptal, it was defective, and it is improving in the resting image. It was also present in the horizontal long axis. We have anterior wall and inferior anteroseptal wall. The inferior and septal, lateral and septal wall, from the anterior to the inferior, all of them